what I'm going to do is I'm going to go through a few slides and talk a little bit about AML in general. And some of it's going to be kind of high level, some of it's going to be a bit detailed, and I hope that it appeals to everyone on some level. And obviously there'll be lots of time to, to go over questions later as well. So in any case, as Mary said, I'm at UC Davis, where I'm now the chief of our division of malignant hematology, cell therapy, and transplantation, and oversee our group there at UC Davis. So some of the objectives of the talk today, I wanted to kind of take you through a little bit of everything when it comes to AML, in terms of epidemiology, meaning who gets AML, what sort of numbers you look at in the US, for example, how the disease occurs, because I think understanding the disease is really important. I spend a lot of time in my new patient visits with anyone that's seen me, kind of trying to explain what the disease is, because a lot of times people end up in the hospital and there's all these things going on and no one ever really sits down and talks to you about what's going on. And so I try to do that in the clinic, but I'll do that here as well. And I want to discuss a little bit about how AML presents, how do we diagnose it, how do we prognosticate, and then we'll outline some high-level therapeutic approaches. I probably wouldn't have time today in a 30-minute talk to talk about a lot of specific regimens, but of course people can ask questions during the Q&A as well. And so I think, these are sort of the questions that people ask me in the clinic that I think kind of are important to I think, understand and wrap your head around what's going on. Obviously, from the get-go, what is AML? And why did I get it? Obviously, other things come to mind later, like what does it mean for my life? How should I be treated? And I add this one in because I'm an academician, but one should always be thinking about clinical trials. And I think some essentials for the informed patient, I think it's important to know what type of AML you have. I think that matters more to some people than others, but certainly whether one has so-called favorable, intermediate, or adverse risk, we can talk about that. So kind of get an idea of as much about your disease version, because AML is not one monolithic thing. There's a lot of different versions of AML. And then, these are somewhat overlapping with the previous slide, but what are some of the treatment goals? Is the goal to cure? Is the goal to, is maybe curative, is a treatment is not an option, then the goal is to control and the disease and have a good quality of life for as long as possible. There's other variations on that. And then the treatment options, again, transplant, the role of transplant is so important for some people, as well as the role of clinical trials. Knowing potential side effects of treatments, I think is very important. Knowing available AML resources like this one and other ones that are out there. And I think this one is, I think it seems obvious, but it needs to be said, which is to try as much as possible to have other people to help, because it takes a village, as the expression says. As an anecdote, my father was recently diagnosed with metastatic melanoma. And for that treatment, he was given IV immunotherapy once a month. And he's in his 80s and actually treated at UC Davis. And I helped take him into the infusion center once a month for his treatment. And gosh, that's like really hard. And I ask my patients to come in twice a week and sometimes 7 days in a row. And it just has been a very eye-opening experience for me to realize how challenging it is just to bring my dad in for one appointment a month, let alone, what I ask my patients to go through. So that was that experience was very important for me personally. So it's hard, and getting a lot of help is very important. So with that being said, some of these are going to be, even slides that I might show a trainee, like a fellow. So hopefully it's not, hopefully it's okay for everyone, but we can always have questions later. But in case anyone wanted to see what an AML cell looked like under the microscope, that's what it looks like on the upper right. That's a whole bunch of these things called blasts. You hear this term blast. And what blast is an immature cell And that's all you can really say. It's just an immature cell. You look under the microscope, and in this case, all you see are blasts, and that's usually not a good thing. There should be a bunch of different cells. There should be heterogeneity, not monotony. And then there's a cell on the bottom right is a type of blast, and you can see those little sticks in there. Those are called Auer rods, and those are something that clues a pathologist into leukemia. It's worth noting that everyone has blasts in their bone marrow, but when there's too many of them, that's when you have AML. Technically, 20% in the old nomenclatures, although that definition is definitely evolving. But what is it? It's a expansion of these immature cells, and they're clonally related. In other words, they're all related to some original cell that got mutated, that made a mistake in its DNA, and then turned into the disease. And then the whole bone marrow is basically now taken over by this population. But it is not one disease. There's many types of AML, and I'll show that to you later. It's a disease that affects folks who are older. The median age in the US is 68. And it's not a super common disease, about 20,000 new cases per year in the United States. And so that's good on one hand, that not many people have to deal with this, but on the other hand, having less patients makes it a little harder to do large clinical trials. Like in breast cancer, you could have 100,000 people in a trial. So we have to rely on smaller data sets. But I'll show you later, we've made a ton of progress in recent years. One of the issues with AML is it causes the bone marrow to fail. And this leads to issues like bleeding, infections, and anemia, because the bone marrow, that's the job of the bone marrow. It's to make the white blood cells that are the immune system, the red blood cells, which carry oxygen and give us energy. And it makes something called platelets, which help us to make blood clots. So when you have AML, these things are not occurring. The bone marrow is not working, and that's what the clinical features are. And what makes AML challenging clinically is that it likes to relapse. And so that's always a big challenge when treating people with this disease. So the risk factors for AML there's a lot of them, but the most common risk factor for AML is aging, getting older. It's a way that our bone marrow ages, essentially. And I'll show another slide that maybe makes this make more sense. But other people can get AML who have had previous blood disorders like myelodysplastic syndrome, which can evolve into AML, or other things like myeloproliferative neoplasms, aplastic anemia, and other things. There's been exposure, there's definitely data for exposure-related AMLs, particularly people who get chemotherapy for other cancers, or certain types of chemotherapy for other cancers, radiation for other cancers. There's been some linkages to benzenes and tobacco. And then there are probably more than we realize that heritable, inherited, germline inherited versions of AML, meaning it's running through the family. And there's some genes that are associated with that. And there's a newer one called DDX41, which is an interesting one because that manifests as AML that occurs in the normal age range. So you wouldn't really think about it. And then we pick these up now in some of these mutation panels that we do. But when somebody's very young, like say they're in their 30s or 40s or even 50s and they have AML, certainly we like to ask about what's going on in other family members. And sometimes we do pick up a familial condition. Okay, so I mentioned earlier that AML is associated with aging, and there was a really interesting, so I think this is a fantastic study. It's kind of old now by medical standards, 2014. So there was this group on the East Coast, and they took a bunch of people out there with normal blood counts. And I'm pretty impressed because they got people all the way up to age 108 on this study. I've never seen that before, but they had people in their 20s all the way above 100. And they took a blood sample from these folks who consented for the study, and they looked for mutations, changes in the DNA that are associated with AML and MDS. And they found that the frequency of these mutations increases with age. So in fact, when you're above 100, 30% of patients had one of these mutations that they could identify in the blood. And you can see the slope of that curve is kind of just going straight up, right? So you could argue that if humans were to live long enough, we'd all have a mutation like this. And then what they found was that the mutations they identified were all the typical ones or many of the typical ones we see with AML and similar diseases like MDS. And the most common one being DNMT3A, ASXL1, and TET2. And so the presence of one of these mutations, was associated with an increased risk of having or developing at some point a blood cancer like AML. And so people with it went from no clonal hematopoiesis, about less than 1% risk, to 4% risk. So it's not a huge absolute value, but it's a 4 times higher level of risk. And so the model that develops is that as we age, the bone marrow picks up a mutation. We call this clonal hematopoiesis. And we have no idea. There's no reason to know that this is even in your bone marrow. You may have normal blood counts for 20 years or something, and you would never even know this is there. And then another mutation occurs later because those cells get a little advantage over their neighbors and they take over, and then they're a little bit abnormal. Then they make another mistake and another mistake, and so on and so forth. And eventually there's a disease. And so it's kind of really 2 ways to look at it. One, it's at this long longitudinal process. Another thing is that it's really kind of the way the bone marrow ages. It just happens, the heart ages in a different way. People get heart attacks. The kidneys age and people get kidney failure. In this case, the bone marrow ages and gets bone marrow failure, and it can manifest as a cancer like AML. I always love this figure because it just looks cool. But this is an image showing the relative frequency of mutations in AML, and also co-local frequencies of them occurring together. So, for example, this DNMT3A mutation likes to co-occur with NPM1. That's what these little intersecting bands mean. But anyway, the most common mutations you see in AML: FLT3, NPM1, DNMT3A. Those are the 3 most common mutations. And I put little red arrows next to ones that we can actually target now with some of our FDA-approved agents. And so there's, when this first came out, there was pretty much, I think, only the top one had anything that potentially targeted. So there's definitely been some improvement in what we can do with targeted agents. So we'll talk about that. So how do we diagnose a patient? So if I've got a brand new a patient who shows up to UC Davis for the first time, and we're suspicious, or even if we know that they have AML and we're trying to confirm it, I do all these tests on what's called a bone marrow biopsy. And so a bone marrow biopsy is basically what we do is the person usually lays on their stomach in a procedure bed. Can be done in the clinic, can be done at the hospital bedside. It doesn't have to be in a special surgery suite or anything. And we numb up the skin with lidocaine, and we wash it, make sure it's clean and sterile. And then we also use lidocaine to numb the surface of the bone and the tissue between the skin and the bone. And then we put a needle into the bone, and we extract kind of 2 different versions of bone marrow. One is like a liquid bone marrow. It looks almost like a blood sample, and it's got particles of bone marrow in it. And then another one is a solid piece of bone marrow. We call that a core. And so we use that to do all these testing, basically. And the testing is going to be things like the pathology, which I showed you a picture of what the blasts look like under the microscope. And then there's other tests called flow cytometry, which is this test where they kind of bind antibodies to the cells and shine lasers on it, and they glow different colors. Anyway, you can tell what markers are on the surface of the cell, and it helps to figure out, is this AML or some other leukemia, and also sometimes some subtypes of AML potentially. And then really important, super important in 2025 is the molecular details of the disease. And so cytogenetics means you're looking at the chromosomes. We all have 46 chromosomes in our bone, in our normal cells. And then in the AML may have more or less, or they may have chromosomes that broke apart and rejoined. So we look for that. And FISH is another way to look at chromosomes. You might see that or hear that mentioned. And then the other big one is molecular mutations. And this is increasingly important as we learn more about this disease. In fact, AML is one of the most molecularly well understood diseases out there. One of the first diseases that had a full genome sequencing done. So the idea of these point mutations, so chromosomes are like millions or billions of DNA bases, and then a point mutation just like one. So it's like a different level of like, it's a much more, uh, like sensitive, it's a much more like at a detailed level as opposed to looking at the whole chromosome basically. And there's a number of mutations that are highly associated with AML. These are a couple panels, and I'm not certainly promoting one company or another, but this is just what we use at UC Davis as an example. And there's these panels that we can send, and there's different ones out there, and some academic centers even have their own internal one. And the idea behind these panels is that we can kind of get data rapidly on patients, right? So somebody comes to the hospital, it's really frustrating sometimes. You do a bone marrow biopsy, and then it takes, like, for some of those bigger reports, it can take like 2 weeks to get the results back. So people recognize that this is not ideal, especially in somebody sitting in the hospital with a disease that may need treatment right away. And so these are kind of faster tests that look for the markers that we can actually do something about. There's a lot of these mutations that we don't have a targeted agent for, and they may be important later for determining whether somebody should have a transplant or not. But these ones that are on the screen here might be actually relevant to what treatment you get. So panels like this, I think, are super useful. There's a newer one that we're using at UC Davis that is a little more extensive, a little more different markers you can see there. That has a 5-day turnaround time. But anyway, you'll see a variation like this at probably most places that treat a lot of AML now. So again, not saying one is right and one is wrong, but the idea of getting some data quickly and using this as an example. Okay, now this is like overwhelming to me, I'm sure it is for everyone, but this is the different types of AML. And when I say AML is a heterogeneous disease, I hope this kind of illustrates that point. This is the classification system in 2016, and I'll show you there's a new one. But there's many, many types of AML. And so, I think it's reasonable to challenge your physician to ask, what type do I have? Because I know for me, I'd like to know that. Because sometimes it matters for clinical treatment purposes. Sometimes it matters for treatment later. But I just like to know. I'm into assigning the accurate terms to things. So, and you might not know this when you first are diagnosed because you don't have all that data back I just talked about. So some of these terms might become more apparent even after treatment has started sometimes. In 2022, the World Health Organization updated their definitions, and I don't think it got any less complicated. And as we learn more and more about AML, which is a good thing, of course, things get more complicated as time goes on. But these are all the different types of AML per the World Health Organization now on the left column. And then there's some other kind of nomenclature stuff on the right. But you can see there's all these different AMLs that are defined by the genetic abnormality that they have. And so, an example is AML with RUNX1T1 fusion, or AML with NPM1 mutation. And so, but you see, there's not all the different mutations are listed here because there's biology associated with certain mutations. And then there's these more kind of catch-all categories like AML, myelodysplasia related, or AML with other defined genetic alterations, because they recognize that there's things that we don't know yet, right? And they're still learning about things. And then if failing that, you can always assign an AML diagnosis based on just what it looks like under the microscope. So this is still reflective of the kind of old school way of doing things before we knew about all these different subtypes of AML. Now, not to overly complicate things, but there's a separate nomenclature that got launched at the same time, something called an international consensus classification. Best as I could tell, there was a fracturing of the pathologist group into two factions that had disagreements about how the nomenclature should be developed. So I think this kind of came out of that. I personally tend to align with the World Health Organization, but I do recognize that this one exists, and oftentimes I'll, as an exercise, I'll figure out what my patient has in terms of both models. But I mean, there's a lot of overlap. One of the big differences on this one is that I mentioned before 20% blasts typically is the definition of AML, but this one has a category of between 10 and 20% that they now call MDS/AML to recognize that there are people that have fewer than 20% blasts that behave, or their disease is behaving like an AML. And I think that's a reasonable that's reasonable of them to think about that, because this, the trouble with categorizing things is with everything, there's not really black and white. Everything, there's definitely somewhere in the middle for some people. Anyway, I just wanted to make you all aware of that. But like I said, I typically use the World Health Organization in my practice. Okay, in terms of prognostication, some of the things that are most important to determining prognosis in AML is number one is age, number two is chromosome changes, and number three are mutations. So I bolded those. Those are the number 1, 2, 3, and probably 4, 5, 6, 7, 8, 9, 10 in terms of what's important. Now there's other things that do factor in, like whether the disease is so-called therapy related. Maybe it's related to previous chemotherapy or radiation. Or if somebody has a previous MDS, that can affect the prognosis. The high white count presentation can sometimes affect prognosis in some of the older models, at least. How patients, we call it performance status, so like kind of how fit they are, and what other medical comorbidities, of course, can have a big impact on what treatment somebody can receive. In the interest of time, I'm going to jump to the current. This is the older nomenclature. This is the older risk category. You can see that there's favorable, intermediate, and adverse risk. And so they, well, maybe I'll spend a minute on here. But you can see that the different categories are based on the mutations and the chromosome changes that the disease has. And so, for example, a favorable disease might be this translocation A21, which carries this RUNX1T1 fusion. Whereas an intermediate risk patient may be somebody who has an NPM1 mutation, also with a FLT3 ITD mutation that has a high level. Or an adverse risk could be somebody with a P53 mutation, and so on and so forth. And there's been studies to look at what this has in terms of impact on prognosis. And blue curve is favorable risk, the gray curve is intermediate risk, and the red curve is, reddish curve is adverse risk. Now, this is for patients who are not treated with transplant as part of their course. But you can see that patients with favorable do better than intermediate, do better than adverse. And you can also see that the age matters, that the curves all shift downward in people who are older compared to people who are younger. And in AML speak, we say older is 60 or above and younger is 60 or below. Now, that doesn't imply a judgment or anything. And in 2025, we're definitely not so ageist anymore. There used to be this whole the idea like, oh, you're too old for a transplant or so on. There's a lot more of like, what's the person in the room with me? They may be 75, but are they fit? Are they, what other medical comorbidities? So we don't necessarily go completely on age anymore, which is a good thing. Anyway, these numbers were, this risk stratification was updated in 2022 with some notable changes that I put some little red asterisks by. Again, this is the slide I might show a fellow, so I'm sorry that it's at a high level of detail like this, but I think the point is that there's still these different categories, favorable, intermediate, adverse, that are determined based on some of these mutations and their chromosome changes. And they tried to simplify things a little bit. But one thing I'll say just at a high level is, generally speaking, for somebody who can take intense chemotherapy, a favorable risk category here typically does not require a transplant, or typically we don't recommend a transplant for those patients in first remission. Maybe if they relapse, we would recommend one. Whereas most people in the intermediate and adverse categories, we would recommend a transplant as part of the treatment course. So that's where this kind of stratification really helps us out. And there's now some new models looking at folks who are older that are treated with a standard of care regimen called azacitidine venetoclax, which we were fortunate enough to help develop at UC Davis. And what you can see is that there's different curves of benefit, high, intermediate, and lower benefit. And this basically depends on what mutations the disease expresses. So for example, if there's a P53 mutation, it tends to be on the lower, the adverse, the lower risk curve here. Or sorry, that would be higher risk. In other words, lower benefit is what I mean to say. And then there's the intermediate curve, which is for mutations with RAS or FLT3, and then anything else goes into the green curve. And this is for older patients who are typically not going to transplant, and they're getting chronic therapy with low intensity therapy. So there's all these different models basically that we can look at, and you might go over such a model with your doctor in the clinic, or even in the hospital if that's where you're being seen. So what about treating the actual disease? I think there's a lot of thought about whether somebody's fit, and when I was a fellow, and it's maybe not so recent as I like to think, but it was probably 14, 15 years ago, we used to walk in the room and we kind of do the eyeball test, kind of look at a patient and be like, you know, okay, they seem kind of fit, so we're going to give them intense chemotherapy, or, oh, that person isn't fit, so unfortunately we can't do that. And we try to be a little more objective than that, but there is still a little bit of subjectivity that goes into this. But when we think about why are we even bothering with this whole fitness thing, we're thinking about who can tolerate the intense chemotherapy versus low intensity chemotherapy. And I'll mention a second what that means. But we think about disease-related features. So you might have somebody who runs a marathon, but their disease features suggest that they're not going to have any chance of responding very well to high-intensity therapy. Well, then it doesn't make a lot of sense to offer that. So there's disease-related features, and then there's also the patient-related features that can affect fitness, like how fit is somebody, how do they have heart disease or diabetes, what is their caregiver situation, other things like that, or how far do they live from the place where they're going to get treatment, and can they get supportive care, and so on and so forth. So there's a lot of factors that go into this. The Italians tried to develop a criteria. It was called the Ferrara criteria. I was very excited. I got to meet Dr. Ferrara in Italy last year, or sorry, in January this year. So I had kind of a fanboy moment meeting him. But anyway, it was they have this model that they developed for patients who are to determine this fitness in a more objective way, to avoid the whole like eyeball thing. And so some of the definitions here: 75 or older, people with heart disease that are defined in a certain way by echocardiogram criteria, people with lung disease, again, defined in a certain way objectively, people on dialysis, people with certain levels of liver disease, active infection that is requiring anti-infective therapy or is resistant to it. There's other cognitive issues that are reported. There's a poor performance status, meaning somebody that can't really get out of the bed, for example, and other sort of, and then there's a catch-all, of course. But so they try to make this criteria a bit more objective, and I think this is an improvement, because just walking in and kind of looking at somebody is certainly not precise. Okay, so a little bit about actual treatments. And I know this is a little small, and the reason is this is a kind of a summary of all the new advances in AML treatment-wise, and it's incredible, really. So the standard treatment of 7+3, the intense chemotherapy regimen, the classic intense chemotherapy regimen, was developed before I was born, early 70s. And then there was the first transplant also in the 70s. But you can see there was nothing approved for over 20 years. And then there was this approval for a very specific subtype of AML, but really 30 years before anything was actually approved for general AML patients. And then it was then taken off the market a few years later because there was some concern about safety. So really, we didn't have much until 2017, and then the floodgates open here. You can just see, like, it's so many different things, like I can't even make it visible. They're all so small. And this is really a good thing. Um, so really it took us 45 years almost, to get from the standard regimen to things that maybe are better now. And the floodgates in the last 8 years have really opened up, and it's really incredible the progress that's been made. Um, and so, yeah, so most of this has occurred after I left fellowship and started practice. It's been really neat to be part of some of these developments personally, but also to see the field really change. And a lot of these are targeted therapies, like, for example, midostaurin is a FLT3 inhibitor and acidinib is an IDH2 inhibitor. There's also different versions of chemotherapy. This one here, liposomal cytarabine and daunorubicin, is another high intensity therapy, but it's in a different kind of package and it works a little differently. All this great stuff. In terms of older patients who are not intense chemotherapy candidates, azacitidine and venetoclax was approved in 2018, and that's really been a game changer. And a lot of these other treatments have really been fantastic. And the most recent one actually came literally, like, I think it was last week. A drug called revumenib was approved by the FDA for NPM1 mutated, relapsed NPM1 mutated patients. And this is a new class of drugs. So there's gonna be a whole another batch of approvals coming. So this is really incredible. Now, taking a step back and like, well, now what do we do with all this new stuff? When you get diagnosed with AML, the only way to, I mean, what I tell people is the way you survive with AML is you have to be in remission. Remission means you can't see the disease under the microscope. And to be cured with AML, you need to be in remission and stay in remission forever. That's how you're cured. So the first step in all patients with AML, in terms of like trying to beat the disease and hopefully cure the disease in some cases, is to get into remission. So we call this remission induction therapy. That's always the first treatment. And so there's, again, this whole fit versus not fit thing. The patients who are fit for induction, we typically use a high intensity regimen. The classic 7+3 from 1973 is still the standard for many people, but now sometimes we can add a targeted agent to it. So for example, if you have a FLT3 mutation, you can add a FLT3 inhibitor together with the 7+3, and those have been shown in randomized studies to improve outcomes. And there's going to be all those things I just showed you on that last slide. There's many studies going on combining those with like 7+3 type regimens, and maybe down the line there's going to be more approvals for kind of combining everything together. Now there's patients who we don't think are fit for this intense chemotherapy because maybe that's too likely to harm them, or there's other issues with intense chemotherapy. You're in the hospital for 4 to 6 weeks, if not longer. It's a long time to be admitted, and not everyone wants that. And so there's other kind of low intensity regimens, like one I mentioned, azacitidine and venetoclax, for example, that have pretty good response rates. In fact, we just finished a study, not finished, but we've done a study and we're waiting for the results, where we compared in people who are fit for induction, the old way of 7+3 versus this low intensity regimen, with the hypothesis that maybe we can get away with giving the low intensity regimens to younger people. So that'll be really interesting to see when that study results. And because I think there's a lot of studies like this that are trying to optimize how we treat people, and maybe less is more in some cases. And then if we achieve our goal and we get into remission, the next step is the post-remission therapy. And so, as I mentioned before, with the goal number one being to get into remission, now we're trying to have people stay in remission forever, if possible. And so this is where we do things like consolidation chemotherapy, where we might give a round of high intensity therapy called cytarabine, high dose cytarabine. And for some people, we try to cure them with just that, the favorable risk patients. We might try to cure them with 4 cycles of 3 to 4 cycles of the high intensity cytarabine. Maybe somebody is not fit for induction and they did the low intensity therapy. So then in those cases, we typically keep the treatment going chronically. So I call it continuation therapy. So you continue the same thing, but I always like tweak it to make people's life better, to make it less frequent, to lower the doses. So for people on chronic therapy, I try to get the obviously the benefit of survival, but also with the benefit of good quality of life. And so you have to try to, that's where the art of it comes into, to try to find the sweet spot for each patient so that they can, um, they need to stay on the treatment, but we can make it more tolerable and manageable and improve the quality of life. And then for many people, transplant is a big part of this. We call allogeneic hematopoietic cell transplant, or some people say stem cell transplant, or some people say bone marrow transplant. They're all kind of the same thing. And this is basically where you get a new immune system from somebody else. And it's not for everyone. And it is a hard procedure, and it has a risk of mortality and other things that can occur, like something called graft versus host disease, for example. But it is typically indicated or recommended for most people who don't have favorable risk disease. You can see an example down here of this data slide I put in. This is a Spanish study looking at people based on this ELN 2022 risk criteria I showed you earlier. And all three of those top curves are people who all these patients are transplanted. And you can see that everyone who gets a transplant, whether they have favorable, intermediate, or adverse risk on this study, at least, all did about the same, which is better than those curves I showed you earlier without a transplant. There still is a group of patients that aren't doing as well that have certain mutations, but that is still looking favorable compared to some of the curves on the other slides. So what I like to tell patients is, with a transplant is really providing a benefit. It's not a guarantee though. We still have to understand or acknowledge that some people with transplant are going to have a relapse anyway, or they're going to have a complication from transplant. So it's definitely an important discussion to have with a transplant doctor if transplant's recommended in your case. And then there's some patients who are going to have maintenance therapy where maybe they don't get a transplant, but there's an FDA approved maintenance therapy for some patients that you can take, again, a chronic therapy. Another topic that we hear about a lot is called MRD, measurable residual disease. And I just had a slide or two on this, and I think that's it for my slides. But these are important tests now, increasingly important in 2025. So again, MRD, measurable residual disease. And what this means is this is disease that we can detect with our ultrasensitive tests now that we can't, like the human eye can look down on a bone marrow pathologist, a really good pathologist looks down at the bone marrow, they can probably discern 1 in 100. That's probably the sensitivity of the human eye. These tests go a lot deeper. So this one here for an NPM1 mutation can go times 10 to the minus 5, right? So like 1 in 10, 1 in 100,000, I mean. So that's way better than the human eye. And we found that people who are MRD positive do worse than people who are MRD negative. And so in a patient like this with an NPM1 mutation that's a favorable risk mutation, if they end up with MRD positivity, then you might favor transplanting that person because the risk of relapse is quite high based on this test. So this is becoming increasingly useful. And then there's other types of MRD testing called flow cytometry, a little less sensitive, but then this can be done on every patient with AML. So I use MRD testing on all of my patients. So that's something you might ask your doctor because it does have an impact on outcomes. So to summarize, kind of hard to cover everything in 30 minutes. I hope it wasn't too fast or too overly detailed, but we'll have some time for Q&A, of course. But AML is heterogeneous and it's not a one-size-fits-all disease, but it is an aggressive cancer and it is, not easy to treat and not easy to have and not easy to help people with. But there is an exciting time right now with many FDA approvals and a lot of really interesting targeted therapies and still more stuff coming through the pipeline. And as such, the standards of care are rapidly changing and evolving in a good way. And of course, clinical trials continue to advance new treatments, which I think we have to remember is very important. And so I think that was it.
Wonderful. Thank you so much for that presentation. It was incredibly helpful. And I think I mean, it gave me a lot of things to think about. Um, so thank you so much for coming on and presenting for us today.
Of course.
So now I'm going to share my screen really quick and we are going to start our Q&A. So I just sent a message in the chat. That's where you can send your questions if you have any um, that you would like to ask that way, and then I can read them to Dr. Jonas. Or if you'd like to just ask your questions verbally, you can use the raise your hand feature, which you can see on the screen what that looks like. And then you can ask those questions verbally. So we're going to give it a second for any of those questions to come in. But while we wait, something that I really liked from the very beginning of your presentation that stood out, it's the first thing I took notes on, was the very beginning when you talked about the keys to being an informed patient. You listed a couple of different things like knowing your subtype and risk, your treatment goals, your treatment options, potential side effects, resources, having a caregiver, things like that.
Mhm.
For someone who is newly diagnosed and is wanting to start tackling some of these things in order to be an informed patient, how do they ask questions? How do they bring up to their doctor that they want more education? I feel like sometimes it can be a little bit intimidating to ask that of a doctor, especially if you're new to them. So what kind of suggestions do you have for someone to begin this journey of becoming an informed patient?
Yeah, that's a great question. And it shouldn't be up to the patient to be on the internet trying to figure that out for themselves either. And I know that happens unfortunately too often. Um, I think it's hard in the so it kind of depends on how you kind of get into the system, so to speak, right? So for people who are and end up getting admitted to the hospital, often there's this like urgency. You get a CBC from your primary care doc because you just went in for a physical or something, and all of a sudden you're getting a phone call at like 10 p.m. saying you got to go to the ER right now. Um, that's how a lot of people present, and it's chaotic, and in the hospital, everyone's just hyper focused on you know on making sure you're stable and getting you through that part, and no one ever has a chance to sit down. And then the folks in the hospital are always so busy. So I guess I'm not answering the question, but in a way, I think the clinic is really I think the clinic is the best time for these discussions. But I think it is fair to ask your doctor, hey, can you sit down can you find a little time to sit down and teach me more about what's going on? Um, it's amazing not many people ask that, and maybe it is because they're scared, they're nervous to ask that. Um, but sometimes I don't know. I think a direct approach is reasonable, but 100%, I think that in the clinic is a really good time. It's a safe time to ask that, and you've got a little more time. But I welcome that when people ask me that directly, but I don't know how others are with that.
Thank you. We have a comment. Someone says that they have CMML1. Can this change to
Mhm.
AML? So maybe you want to talk a little bit about those progression of disease from some of those more precursor conditions.
Yeah, that's a great question. Thanks for asking that. I think um, the diseases like CMML, MDS, other kind of myeloid malignancies, they certainly can progress to AML. And each one of those diseases has a risk model, just like I was showing the risk model for AML of adverse, intermediate, and so on. CMML has its own risk models. I use one called the CPSS molecular, and you can put in your information, or your doctor should put in your information about how many blasts are in the bone marrow, what mutations are there, what the blood counts look like. And then that can give you a model that predicts whether you have a high, low, or an intermediate risk of progression to AML. And obviously, these are models, and nothing's perfect. The person in the room with you is N of one, so they're either going to have it happen or not. But the models can help your doctor with how to treat you, because there are some treatments that have been shown to delay or prevent progression to AML. And in some cases, even a bone marrow transplant can be indicated before the disease progresses to AML. So definitely it's a thing that can happen. But there are some people with CMML, MDS, and other diseases like that have a very low risk of progression to AML, and it never is a problem for them. And these diseases can even become passengers. And what I mean by that is um, you might grow old and just have this disease in the background, and it never causes you trouble. Um, anyway, that's where these models try their best to kind of help steer the clinician and how to guide you forward in that journey.
We have another question. Says, is it possible that anemia could be the beginning of AML if they can't find out where you're losing blood?
That's an interesting question. I think that's possible. A good anemia workup is going to include when I think about anemia as a clinician, or at least when I'm teaching medical students and things like that, you kind of think about why is somebody, taking a step back, why is somebody anemic? Is it because the bone marrow isn't making enough red blood cells? Is it because the body is losing red blood cells? Or is it because the red cells are being destroyed within the body, or maybe the red cells are getting stuck somewhere? And so those are kind of the main ways that you become anemic. And so if somebody does a thorough workup to make sure you're not losing blood, like maybe a colonoscopy or something like that, another workup there, and then they do some blood tests to make sure that there's not what we call hemolysis, which is the red blood cells breaking apart, and then maybe somebody doesn't have a big spleen, and maybe there's no iron deficiency. Once you kind of rule out all the things that typically cause anemia, then you might be left with maybe there's a problem in the bone marrow. And so then in that case, usually a bone marrow biopsy is recommended, and sometimes that's how we pick up a disease like AML. Um, it's interesting. The disease can present in so many different ways, um, and I feel bad sometimes for the primary care docs because it's not always easy for them to recognize AML. Some people, it's like they have a cold, and they get like a course of Augmentin or something for a sinus, and then it turns out that was their leukemia presenting. And that's not to say everyone that gets a cold should be treated should be getting a bone marrow biopsy. It's tough, right? You can imagine. So absolutely, an anemia could be the initial presentation. Some people have no symptoms whatsoever, as well. It's challenging.
Yeah, I think that really highlights how complicated of a disease AML can be, not just in treatments, but also in even getting that diagnosis, which ends up being a lot of problems for a lot of people. We have another question. Said my mother had polycythemia for 12 years before it progressed to AML in August. She had 2 rounds of chemo, 1 week of chemo, and then 3 weeks off, and it's been hell, swollen feet and legs, pain in her legs, etc. What integrative therapies are there? They said that that's a new term to them.
Yeah, that's an interesting question too. And exactly what is meant by integrative therapies is sometimes not 100% clear to me. But in terms of there's there are different things that people do as adjuncts. There's evidence for dietary modifications. There's acupuncture and other things that people will do. There's alternative, what I think Western medicine likes to call it alternative medicine. There's different terms for it. Um, and I think the challenge is that there's not a ton of connection between everything, right? And I think I'm obviously a Western medicine guy, and that's the way I was trained, and that's what I do. And there's not a lot of of integration, is the word is right there. And so I think what I would say, my main message when people want to try other things is that it needs to be, in my opinion, in connection, in addition to the standard treatment. So it looks like this person's getting, my guess is azacitidine, or something like that for the disease, and it sounds like it's been tough. And so I think, but that's a key part of the picture then that probably needs to continue, but maybe there needs to be dose adjustments, or there needs to be modifications, or maybe there needs to be a change in treatment if it's not tolerable. Some people will need additional things like diuretics and even pain medications. But then on the flip side, if somebody wants to, and I have patients that do this, they want to take a supplement, or they want to see somebody who does another type of medicine. I'm perfectly fine with that. What I like to recommend is that they make sure that we know what they're taking, so that we can talk to the pharmacist and make sure that there's no interactions between like supplements and the chemotherapy, um, so that we're not creating problems there that we didn't anticipate. So, like I said, I support people trying other approaches. I think that, but I think being, kind of clear with your team about what you're doing is important so that people can make sure that, there's no interactions. I don't know if I answered the question very well because it is a subject that comes up on occasion. Um, but there's also things like dietary consults, like in the hospital, we have patients see dietitians. We have patients who, there's other things that people do, massage therapy, and like I said, acupuncture. We have to be a little mindful with the blood counts when you start doing certain things. But anyway, okay, good. It seems like I got to the question. Okay.
Yes, and Michelle, I can also send afterwards. We have some resources that kind of answer some of these questions. So I can send those to you in an email after this as well, just to give you some extra insights that you can keep. Um, Well, it looks like that is all of our questions and takes us right up to the end of our time together today. So I just wanted to say thank you again to Dr. Jonas for taking time to prepare for us and for being willing to come and speak and answer questions. I think it was incredibly helpful, and we're really grateful for your time and for your presentation.
Thank you very much. I really appreciate it. And thanks for the opportunity to talk and see everyone here online. And I think my email is on there, so I'm always happy to. And I think I'll be on, right. I'll be on the list of people on your
Yes.
website. So
Yes.
um, thank you for this opportunity. It's really amazing.
I wanted to really quick before everyone leaves, we have a learning survey that I mentioned at the beginning of the webinar today. This is to help us see how you enjoyed the webinar today, what kinds of things are your main takeaways. I tried to make it painless and as easy as possible. It's 8 questions. Most of them are multiple choice, and then there are 2 open text questions at the end just for your thoughts that really are helpful to us. I'm adding the survey link to the chat right now, so you can either click it there and so you can take it afterwards, or I'll add it to the email that you're going to get after this event so you can just fill it out then. This helps us to know how we're doing and helps us to prepare content for the upcoming year. I also mentioned at the beginning that I was going to share some additional resources. So I wanted to share about 2 other nonprofits that help to supplement in areas that we don't have resources in. So at HealthTree, we have a lot of resources at your fingertips for education, for peer support, volunteer opportunities. But in terms of logistical help or financial assistance in some of these ways, we don't have. So I wanted to highlight those so that everyone is aware and can access these information. Also, these links will be in the event email that goes out afterwards as well. So you'll have access to it there. I wanted to start with the American Cancer Society. I think it's a name that everyone's heard of, but they have a lot of programs that I think people aren't necessarily aware of. So, one of the programs I think is really incredible is called the Road to Recovery. And through this program, they will help provide you with rides to and from your medical appointments. So, that can be a big barrier for a lot of people, especially if you don't necessarily have a caregiver available to you, or you live or you don't have access to a vehicle. So, this is the phone number. Again, I'll send it in the email, but it varies city to city because it is volunteer based. But if you call this number and let them know what your need is, they'll help you get rides scheduled to your appointments. And the next one is the Healthwell Foundation. They're a nonprofit that has disease and condition based funds that are then available to you to help cover medical costs after your insurance. So they have a fund that's specifically for AML, and they open it up anytime they get donations into it. This fund currently is for covering AML medications, and they have a list of medications that are covered on their fund page. I scrolled through it, and it looks like most of the medications I've heard of patients taking when I meet with patients one on one are all on the list, but definitely give it a look and see if any of the medications you're taking are covered and you can get a little bit of extra help. You can follow them on social media that's where they announce when the funds are open and when they close. They also have a text feature, and that's what I've done. I've signed up for their fund text so that I can make people aware when it's open and closed, but that can be a way that you can get access to it quickly. I checked just this morning and the fund is open currently. So if you need help with your medications, this is a nonprofit that you can go to that can give you some of that help. And then again, I'll have a link to this in the email that goes out. I again just want to thank our sponsor for this regional learning series, which is AbbVie, and their support made this webinar possible. And then in closing, I just wanted to say a thank you for being a part of our AML community and for attending our event today. Your support means a lot, and I'm really grateful to have you here. I've included my email on this slide, so please don't hesitate to reach out if you have any questions about HealthTree, our programs, if you're interested in sharing your experience. I set aside time every week to meet with community members. It really benefits me to be able to know what's going on with members of our community so that I can best create an educational curriculum that answers the questions that you have. And I just generally like to meet you. So if that's something you're interested in, please reach out. It's one of my favorite parts of my job. So I'd really love to meet with you. And right now, I'm developing my curriculum for 2026. So if you want questions that you have answered, right now is the best time to get them to me so I can have them built in. I really appreciate all of you, and I hope that each of you has a wonderful rest of your day and that we'll see you on some of our webinars soon.